All right, we're live from my perspective. All right. Do you reckon we should give another minute to wait for people?
Yeah, I think maybe.
Like 1 or 2 minutes, and then
Yeah, there's no rush.
yeah. No, let's give 1 or 2 minutes, and we'll start shortly. For those of you watching already, if you have a minute to spare, if you don't mind scanning that QR code, it's some of the data we're currently collecting on some research on medical education. So that'd be really, really beneficial to us if you just don't mind giving that a quick scan. And it's a brief survey basically. All right, should we make a start, Alex?
Yeah, sure.
Sure. So hi everyone. Thanks for joining us. I hope some more people are going to trickle in, but we might as well get some start. So my name is Millie. I'm one of the F1 doctors. I currently work in London, and I've got Alex with me. Alex, if you want to introduce yourself as well.
Hi, yes, I'm Alex. I'm an F1 currently working in Manchester.
And we're going to be taking you through today's session, which is on cardiology. Really staple, really basic stuff that we're going to cover through. So we're going to cover over some chest pain, hypertension, heart failure, some arrhythmias, including some ECGs, ischemic heart disease, and cardiac auscultation as well. It's all kind of based on the curriculum of the UKMLA. So it's some basic stuff that is really going to give a good, some really good knowledge for your exams, hopefully. And yeah, let's get started. So we've got question 1 for you guys.
So, question 1, I'll just read it out. So, a 55-year-old Caucasian man presents to the GP for his regular blood pressure monitoring appointment. In clinic, his BP is 151/97. His past medical history includes hypertension, type 2 diabetes, and CKD. His current medications include atorvastatin, ramipril, amlodipine, and dapagliflozin. There's some blood tests there. What is the most appropriate next step in his treatment?
I can see we've got some answers in the poll already, so do keep voting if you know the answer. I'm just going to give you a few more seconds so people can get their vote in as well. All right, I'm going to go to the next slide.
Okay, so the answer was A, indapamide. And we get to why that was the correct answer. when we look through the algorithm for medications and how you sort of add medications on. So firstly, we'll look at how to diagnose and then when to treat hypertension. So key things are, if a patient presents to the GP, they have their blood pressure taken, and it's over 140/90, then you offer ambulatory blood pressure monitoring. If it's over 180, over 120, then that's an immediate referral to specialist care, a specialist assessment. So if they've gone and done their ambulatory blood pressure monitoring, and then they come back, and that's reported as over 135, over 85, then you start treatment. So it's as simple as that. So you'd never start treatment off of just one blood pressure monitor reading. So if we go to the next slide. So this is the algorithm for which medications you start patients on and then which ones you add in. Really important to know this like the back of your hand. So essentially it starts off with two groups, less than 55 or over 55. If you're over 55 but have type 2 diabetes, then you're put over onto the left side. However, if you're under 55 but Black African or African Caribbean ethnicity, then you go over to the right side. So firstly, you're adding an ACE inhibitor, ARB, or calcium channel blocker. Then after that, you're adding either a thiazide-like diuretic, and depending on what you added first, either a calcium channel blocker or an ACE inhibitor or an ARB. Then after that, if they're still not sort of within the target range, which is less than 135 over 85, then you'd consider adding another a third agent. So it's all three of them. So whichever one out of the previous three that you haven't added, you have that in at this point. And then after that, you add a fourth agent, and this depends on the potassium level. So if the potassium is less than 4.5, then you add Spiro, and if it's more than 4.5, because Spiro, aldosterone antagonist, and potassium sparing, if it's over 4.5, you add an alpha blocker or beta blocker instead. Really key to understand this slide and know it really well. So this is the next question. I won't read it out this time.
I got one answer and two answers in the poll, so keep answering if you know. Alright, I'm gonna go forward and reveal the answer in 3, 2, 1. Here you go.
Okay, so the answer is prasugrel. So classic presentation of a STEMI, and actually we give you the fact that there was ST elevation. It's quite a difficult question actually, and I think it required some clinical judgment to actually rule out some of the answers, rather than just knowing straight away what the right answer might be. So if we go to the next slide, this is the algorithm for treating a STEMI, and hopefully if you'd correctly followed this, you would have realised prasugrel was the correct answer. So the patient had had their 300 milligrams of aspirin, and then because they presented within 12 hours of the onset of symptoms, and because PCI could be offered within 2 hours, we follow the side of the algorithm for proceeding with the PCI. And what it actually says is you offer prasugrel, so a second antiplatelet to the aspirin already given prior to going for the PCI. So it's prasugrel if they're not taking another oral anticoagulant. If they are taking an oral anticoagulant, then you can give them oral clopidogrel instead. So you do that before the procedure. During the procedure, during PCI, which is now usually done by radial access, you give unfractionated heparin, and then there's also an option for a bailout GPI, which so essentially bailout meaning if a complication occurs, such as if there's a reformation of the thrombus, or if there's occlusion of the vessel, then you can give an antiplatelet again. So hopefully that clears it up, and it's sort of quite a simple sort of structure to try and remember. If the PCI couldn't be offered within the 2 hours, then they'd need to go for thrombolysis, which is what the outer plays was. However, the question said that they were able to go for the PCI. In terms of NSTEMI, it's similar. However, you do a GRACE score after you give the 300 milligrams of aspirin. GRACE score is essentially a 6-month percentage mortality. If it's over 3%, then you can offer PCI. If it can be given within the 2 hours. Otherwise, you offer conservative management. So secondary prevention, really important. So dual antiplatelet, aspirin lifelong, and a second antiplatelet for 12 months. ACE inhibitors help with cardiac remodeling, key fat there. Beta blocker statin, aldosterone antagonists, and then especially for stuff like OSCEs, don't forget cardiac rehabilitation, lifestyle advice, and like further cardiac monitoring, such as sort of ejection fraction that would get followed up with these patients. So complications of an MI. So start off with sort of the more straightforward things, sort of things that are easy to understand. So cardiac arrest, cardiogenic shock, and then you can develop chronic heart failure. Cardiac arrest that might be due to a VF, other arrhythmias. So if you have an inferior MI, you can get a AV block, because inferior MI, you're then knocking out your SAN node. You can get pericarditis within 48 hours of the event. However, if the patient presents with pericarditis-like symptoms, but 2 to 6 weeks after the event, that's Dressler syndrome, and very similar presentation. You actually treat it with NSAIDs as well. Other complications, so left ventricular aneurysm, important because you can form thrombuses that can develop, so you can develop a stroke from that. You can have ventricular rupture. So this is when you get a cardiac tamponade. So you present with Beck's triad, raised JVP, hypertension, muffled heart sounds, and that actually leads to acute heart failure. Occurs 1 to 2 weeks after the MI. You need urgent pericardiocentesis. Other things, you can get a VSD, so it occurs about a week after the event. Develop a pansystolic murmur and acute heart failure. Really important to get the TTE and ultimately surgery. And then mitral regurg may develop due to the rupture of the papillary muscles. Go to the next slide. Question 3.
All right, I'm going to move on. I think a lot of you have already answered.
So the answer, PIC span for 3 months. So hopefully most of you know that you treat a PE with a DOAC. So I guess sort of the other thing to think about with this question is the length of the treatment, which we'll get on to when we go through management. So just thinking about a PE, so if you suspect a PE, then you do your Wales score for a PE. There's a different one for a DVT, so it's important to know that. If they score over a 4, then a PE is likely, and you go straight for a CTPA. If that confirms a PE, then you obviously treat, and if it doesn't, then you consider another diagnosis. If it's 4 or less, then it's unlikely. You do a D dimer. If that's positive, you go to a CTPA. If it's negative, then you're not going to treat and you'll consider another diagnosis. So this lady had a score of 4.5. Because a PE was probably the most likely diagnosis in this situation, given her presentation. And she'd had surgery in the previous 4 weeks. She had a lap chole 3 weeks ago. So just important to know that it's surgery actually within the past 4 weeks. You know, it seems like quite a long time to sort of develop a sort of a PE that sort of like 3 to 4 weeks later, but important to know. Okay, so we can go to the next slide. So treatment, so it's a DOAC now, and you have a choice of a apixaban or rivaroxaban. And then in terms of how long you treat for, so it's broken down into provoked, unprovoked, and cancer. So cancer, it's between 3 and 6 months. If it's provoked, such as the case here, so it was likely provoked by the surgery that you'd have 3 weeks ago, you treat for 3 months. If it's unprovoked, then you treat for 6 months. So it's important to look at her vitals, see if she's hemodynamically stable, any other compromise. So say she'd really dropped her BP, then you consider thrombolysis. And in recurrent Ps, you'd consider a filter as well. So DVT is very, very similar process. So you actually do, so as I said, you do a Wales score, but specifically for the DVT. If it's 2 or more points, then you'd go straight to the ultrasound. If that's positive, you treat. If it's negative, you do a D-dimer, and then you go from there. If that's positive, then you treat. If it's negative, or if the D-dimer is positive but the scan's negative, you don't treat. You repeat the scan after a week, and you go from there. However, if the Welsh score is less than 2, then a DVT is unlikely. You go to a D-dimer. If the D-dimer is positive, you go for a scan. If the D-dimer is negative, then you consider another diagnosis. And the treatment's the same as a PE, so you do a DOAC for 3 to 6 months, 3 or 6 months, depending on if the DVT was provoked or not.
All right, just waiting for a few more answers. You can see we've got some answers for E. All right, I'm going to reveal the answer now. So in this case, we would actually add a calcium channel blocker. So essentially, this is a gentleman who has stable angina, and he's currently on a beta blocker, as well as aspirin and a statin. And it's asking you, so he's still symptomatic. So it's asking you, how can you manage this guy, essentially. So in terms of stable angina, so it is in stable angina, symptoms only occur when you exercise or when you walk. They don't occur at rest. In terms of how we manage it, so lifestyle modifications, as Alex was saying earlier, always important. Everyone should be on that. However, drug treatment is also very important. So all patients should be on an aspirin, like this patient, and a statin and a GTN spray sublingually. So that's your first baseline for every patient. Then you add a beta blocker or a calcium channel blocker. And it's important that you should go for amlodipine or diltiazem instead of varenicline. And then you need to max that one out if the patient is still symptomatic. So max it out until the maximum tolerated dose, which it did tell you in the question that he's already been on that. And then the next step would just be to add either or the other. If they can't tolerate it, so for example, if someone's got asthma and they can't tolerate a beta blocker, you could add long-acting nitrate, ivermectin, or nicorandril, or ranitidine as well. Surgery, which I know is one of the options that some of you guys picked, is only if the drug treatment is optimized and they're still symptomatic, then we can consider something like a cabbage or a PCI. Yeah, moving on to the next question. As always, Paula should be up in the chat right now, so please answer if you know. All right, I'm gonna reveal the answer in 3, 2, 1.
Okay, so this is a patient with chronic heart failure, and we go through the treatment. I think I start talking about the oh no, okay. So just quick, because there's another heart failure question, then we'll just talk overall about heart failure. So just to go through this quickly, so patients already on an ARB and a beta blocker for their heart failure, still symptomatic. However, the question's asking which medication be started to reduce the risk of mortality rather than improve symptoms. There's an algorithm we'll show you, but that's why you'd go for eplerenone, which is an aldosterone antagonist, over the furosemide. And we'll get to what that is in a second. We'll just go for the second heart failure question now, though.
All right, I'm going to reveal the answer now.
Okay, so again, so this is just a question where you need to know your New York heart failure classification. We'll go through it actually on the next slide. If we go through to the next slide, then it's there. So we'll start with the diagnosis of heart failure to begin with. So again, when you're working up a patient you suspect for heart failure, don't forget your basic investigations. Then you're going to go for a BMP. Important to know with BMP, there is two types. Have the most common one, NT-proBNP. It's not specific for heart failure. So there are certain instances, such as if you're on an ACE inhibitor, where your BNP would be falsely lowered, or if you're elderly, then it can be falsely raised. However, if your BNP is between 400 and 2,000, you have a TTE, so an echo within 6 weeks. If it's over 2,000, you get it more urgently. So if it's over 2,000, you get it within 2 weeks, the echo. That's because there's a worse prognosis associated with the higher the BNP. When you get your echo, that's when you diagnose heart failure. And there's two categories, so preserved and non-preserved ejection fraction. So as I'm sure a lot of you remember, so ejection fraction is the percentage of blood within the heart that leaves the heart every beat. So it's preserved if it's over 50 and non-preserved if it's less than 50%, indicating either diastolic or systolic dysfunction. Moving on to the New York heart failure classification, so it's between 1 and 4, so not the 1 and 5, which might have tricked a few people up. So 1 is essentially no limitations, can do ordinary activity with no symptoms. 2 is sort of on exertion. They get symptoms, fatigue, difficulty breathing. 3 is when they do any form of physical activity, so even just moving around the house, that's when the symptoms are going to come on. And then 4 is when symptoms come on even at rest. So we can go on to the treatment of heart failure. The next slide. So loop diuretics, like furosemide, don't actually improve the mortality risk. So they're purely symptomatic for symptomatic control. So you can add them to anyone who you feel needs it, and then you split your treatment of heart failure into if they have a reduced ejection fraction or preserved. If it's reduced, so less than 50%, then you immediately start them both an ACE inhibitor or a beta blocker. If they can't tolerate the ACE inhibitor, then you can try them on an ARB. Then the next medication up, so your aldosterone antagonist, so aleparone. And this is where we were with the first question on heart failure. So we'd already started them on 2. So this is the next stage. SGLT2 inhibitors. So I checked today, and although they're strongly recommended for the treatment of heart failure to improve the outcome, they're not actually written into the NICE guidelines yet. And then you have your sort of third line medications, which are started by your specialist. And on the next slide, we can go through sort of when you consider starting each one. But I think it's important just for finals to have an idea that they can be used as sort of third line medications. Other important considerations, so cardiac resynchronization therapy, so you can have a biventricular pacemaker, so that this is when you have a lead in the left atrium and then the left and right ventricle, and that can help contract the heart, sort of synchronize that contraction to improve the ejection fraction. If they've had previous VT or VF, then you consider an ICD, then also valvular surgery, such as if they have aortic stenosis. If they have preserved ejection fraction, then you only treat the comorbidities and if they have congestive symptoms. And other important things are the annual flu jab and the one-off pneumococcal vaccine for all patients. And this is that flow diagram probably explaining what I just said there a bit more concisely and neatly. You can see where you add in your sort of third line medications like ivermectin and digoxin, and it's quite specific situation, which I think you'd be unlucky if they did ask you a question that mean in your exams, but maybe have a read over it so you're not completely taken aback. But essentially that slide just summarises what I just spoke about. So quickly, just speaking about acute left ventricular failure, so acute heart failure. So common causes, so sepsis and MI that rapidly reduces the efficiency of the heart. Your classic ECG chest X-ray findings, so A to E. So alveolar edema, which you can see is sort of this bat wing appearance, and you can see, I don't think I can show you my cursor, but it's by the N of effusion, sort of that opacification. That's sort of one of the bat wings. You have the curly B lines, you have cardiomegaly, you have pleural effusion, and then you have dilated upper vessels. Important just to be able to find those signs on chest X-ray, could come up in an OSCE. In terms of management, it's relatively quite straightforward to begin with. So you sit the patient up, furosemide, CPAP, important to stop any IV fluids as well. And then you have more specialist input for supporting the cardiovascular system. So ionotropic agents, they increase the cardiac output, like millerone. And then you have your vasopressors, which increase the blood pressure by causing vasoconstriction, and that's your adrenalines and vasopressin. And just put a last point there where you only stop the beta blocker if they go into shock, heart block, or if they have a a heart rate of less than 50 beats per minute.
All right, let's move on to some ECG questions. So we've got this ECG here. I'm just going to put the poll up. All right, I'm just going to give you guys a few more seconds, and then we're going to move on and reveal the answer of that. I appreciate it's quite a complex ECG, but we're going to get to why that is. So this ECG shows you a bifascicular block, and we're going to go over in detail in a bit of what that is. But essentially we can see a bundle branch block here, and we also have some axis deviations as seen in leads 1 and AVF, which makes up the bifascicular block. But we're going to go over it in detail. So in terms of ECG interpretation, I'm just going to go through the steps of what it makes up a good ECG interpretation anyway, so you don't get caught on. First thing I would look at would be the rate. So there's two ways to do it. If it's regular, you can just go 300 divided by the number of large squares in between each QRS block. Or you can just count the number of the QRS complexes on the rhythm strip, which is the one at the bottom, 10 seconds, and time it by 6. That's specifically good if it's irregular, for example, like AF, because if the rhythm is irregular, the first method is not going to work. So straightforward, and then you say if it's normal rate, tachycardic, or bradycardic. Then I'll have to look at the axis. Axis, I know, something that used to trip me out when I was a medical student. But essentially, look at leads 1 and look at leads AVF. They should both be positive, which means they should both be directing upwards or predominantly upwards reflection. That's a normal axis. If lead 1 is negative going downwards and lead AVF is positive going upwards, so they're kind of reaching each other, that's a right axis deviation. And if it's 1 is positive and AVF is negative, they're leaving each other, which means that it's a left axis deviation. There are some more formal ways to do it as well, but I think this is a method that's pretty foolproof and works for most of the cases. In terms of causes of left axis and right axis deviation, left axis can be normal in adults. Right axis can also be normal in children and infant adults. Both, so left axis would be by left ventricular hypertrophy, left anterior hemiblock, an inferior MI can present with that, or hyperkalemia and VT. And then in the right axis deviation, you get right ventricular hypertrophy, the left posterior hemiblock, an anterolateral MI, septal defect, and respiratory distress. I would focus on the right ventricular hypertrophy. That's a very common case for those. Okay. Then moving on after axis, have a look at the rhythm. So look at the QRS complexes in the rhythm strip. Is it regular? So you can use a piece of paper, see if the distance in between is always the same. If it's irregular, have a look if it's regularly irregular. So for example, if it's skipping a beat after every 3, or if it's completely random. That's really important to know as well. After that, have a look at your P waves and see if the P waves are followed all the time by a QRS complex. If not, we might be thinking about some type of heart block. And then also just have a look at the morphology. So they could be peaked, they could be flat, they could be absent, things like that could indicate certain things. Look at the PR intervals. So usually that's between 3 and 5 small squares. It can be prolonged. For example, if only the thing is prolonged, then it would be first degree heart blocked. It can also be shortened in things like Wolff-Parker's invite. And if the PR interval is depressed, that's often a sign in pericarditis. All right, so after the PR, we're going to have a look at QRS. So QRS complexes should be narrow. Narrow means normal, so that's less than 3 squares. If they're broader than 3 small squares, that suggests a bundle branch block. The QRS complex can also be quite tall, so if they're almost reaching into another strip, that suggests that maybe there's some hypertrophy from the ventricles. Okay, and then we're going to have a thorough look of the bundle branch blocks in a second. QT interval, so you can use QT. Sometimes, especially if the heart rate's quite elevated, you have to do QTC, which is just corrective for the heart rate that you have. As a rule of thumb, it's slightly different in men and women, but as a rule of thumb, everything greater than 0.45 seconds is prolonged, and that's really important to know. There's some drugs that cause it. So, for example, can't remember off the top of my head. There's certain things on promethazine have come along. Promethazine can elongate it, so just have a look at the drug chart and see what's happening there. Hypothermia, hyperkalemia, hypercalcemia, hypothyroidism, familial, so long QT syndrome. The list goes on. So those are some causes of long QT syndrome. After the QT, we're going to jump to the ST segment. So ST segment, of course, really important because we're looking for ST elevation in things like STEMIs. We can also, when ST segments are depressed, that could indicate ischemia. There's different types of ST elevations. So on the top right, for example, you can see kind of your typical Brugada sign. So that's what it kind of looks like. You've got all sorts of areas of ST elevations just on the left there. Some tombstone morphology, which is a really bad indicator. We've also got some sloping ST, so upsloping ST elevation here, which is significant for pericarditis. Then after ST, we'll just have a look at the T waves. T waves, they can be flattered or inverted, which is often normal, but it could be a sign of ischemia or hyperkalemia. If they're peaked, such as the image on the right side on the top, significantly peaked, that is a sign of hyperkalemia, which is a very worrisome sign. And then lastly, something that shouldn't be on ECG is a U wave. So that's the thing that comes after your T wave and before your next P wave. Usually it leads V2, V3, and is significant for hypokalemia. And that's it. Those are your steps for ECG. Just a little bit more on bundle branch blocks because they're quite confusing. So how I would remember it is with William Marrow. So William has two L's in the middle, which means it's left bundle branch block. And in V1, your QRS complexes are going to look like a W, so predominantly negative below. And then in V6, they're going to be upwards, so kind of resembling an M in a very in a wide way. And then the opposite goes for the right bundle branch. So you're going to have an M-shaped V1 QRS complex and more of an N or W, but N-shaped complex in V6. So that's what it looks like. So as you guys can see, these both have quite wide QRS complex as well, so they're going to be quite broad. There's loads of different causes for bundle branch blocks as well. I'm not going to go over in detail. And now these are more blocks, say, to answer the question that we had in the beginning. So a bifascicular block means that we have a right bundle branch block, which we had in the ECG, so that's the same ECG. And then you have a fascicular block as well, which is essentially meaning an axis deviation. So this case, I can't actually see it now, but I think they're leaving each other, so it's a left axis deviation. And then in a trifascicular block, you have a bifascicular block, so you have both of these, and then you also have a third-degree heart block. However, amongst researching for this presentation, I found out that often actually people also use it with first and second-degree heart block, but that's not strictly speaking a trifascicular block. So yeah, that are your blocks. And we'll move on to question 8. Just gonna put the poll up as well. I do appreciate it. It's quite small probably on your screen. I'm trying to see it as well. Don't know if there's a way to zoom in, to be honest. But yeah, I'm just going to go ahead. I know some people have answered already. So yeah, well done to those answered in the chat. It is atrial fibrillation. So you can see I've started to map out the rhythm and it's irregular. And then on further inspection, you would see that there's not really any P waves either. So very significant for atrial fibrillation. So we'll just have a quick talk about that. So atrial fibrillation is a disorganized atrial electrical activity and contractions There's many different causes. I would just focus on the first few that are up on the top. So things like ischemic heart disease, hypertension, and valvular disease. It's really common in patients, specifically older patients. Excuse me. So you're going to see it a lot on the wards, actually. So in terms of the ECGs, so you're going to have an irregular rhythm like we had in the ECG and no peak waves. You can also have fibrillatory waves, which sometimes can appear like there's actually P waves. So those are just some fine scribbles. They can be really fine or they can be coarse depending on the altitude that they take. The ventricular rate is variable. It's commonly quite fast, so we'd call it fast. And then it can also be normal rate, so it'd be things like slow AF. Specifically, if someone's already on things like a beta blocker, it can just actually appear a normal rate. QRS complexes should be narrow, but again, could be an underlying pre-existing bundle branch block, so they will be narrow, so wide. So if they're wide, don't let that confuse you. Patients will usually have palpitations, dyspnea, and chest pain. They have irregular pulse, and then they might also present with an embolic event, so a blood clot in some form. So there's a few different types of AF. So it can be your first episode, or it can be recurrent. Sometimes AF comes in self-terminate itself, which is called paroxysmal AF, or it can be persistent, and it can be long-standing as well. In terms of management, it's quite straightforward, but it can also be quite confusing. So the vast majority of cases are going to be for rate control. So rate control you're going to achieve by either a beta blocker or a calcium blocker. Has to be rate limiting. And then if that doesn't control it, then you can also go for combo therapy, also with either of these or with digoxin, so maximum of 2. Then after that, rhythm control is also often indicated. So for example, if they have heart failure, with that, if it's a new onset AF, so the first episode, or if there's things to be like a reversible cause, so an electrolyte disturbance, for example, then you might think about rhythm control instead of rate control. So that can be with a drug therapy. So drug therapy is usually used when the symptoms have been going on for less than 48 hours, but it is contraindicated if there's any structural heart disease. And then you can also cardioverse them. Usually that's required if they have been symptomatic for longer than 48 hours, or if they're hemodynamically unstable. So if they're shocking, then you're going to have to cardioverse them. If during cardioversion there's a great increase of an emboli, that can cause the stroke, so it can be dislodged. Hence, if it's less than 48 hours of symptoms, or you're going to have to anticoagulate them before cardioverting them. Just for the risk of stroke, make sure to calculate the CHA2DS2-VASc score. Do offer anticoagulation if there's 2 or more, or if it's 1 for men as well, because women get 1 for their gender anyway. First line would be a DOAC, second line warfarin, but we do try and get everyone a DOAC nowadays because there's less monitoring. And then also make sure that the bleeding risk is not increased, so do an orbit score as well, and then take it from there. All right. Moving on to question number 9, almost there. So just going to get the poll up again. All right, got some answers already, so I'm a spirit of time. I'm just going to move on. So in this case, your most appropriate initial management would be amiodarone, and we're going to go over with this why that is. So this ECG shows ventricular tachycardia. So VT for short, so it's a broad complex tachycardia. So as you can see, all of those QRS complexes are really wide. So it comes from the ventricles. In this case, the most common type is a monomorphic VT, so it has a single point of origin. Most common cause would be IHD, can also be due to cardiomyopathy or Chagas disease as well. Then this is just to point out really that VT can look very, very different depending on the shape and also on the width of the QRS complex. So just look at loads of ECGs and kind of get used to this, really. And why is VT important? So VT impairs your cardiac output because your heart is beating so fast. You're actually going to have decreased, and it's really going to impair with you. It can lead to a hypertension, which can lead to collapse and acute cardiac failure. It can also decrease your myocardial perfusion, which is not good for your heart, and it can also degenerate to VF if you don't treat it straight away. Okay, so there is different types of VT. VT is actually quite a broad category. So there's things like monomorphic, which we've touched on. There's polymorphic. There's also torsade de pointes, which is a polymorphic VT with QT prolongation, which you can see on the right here in the white bigger ECG. There's a few other ones as well that I wouldn't worry about. And then there's VF, which is the one in the bottom rhythm strip, which shows your fibrillating waves. People can be stable or unstable with it. It can be sustained or it can be non-sustained as well. So people can self-terminate as well with that. All right, so similarly, so if someone's unstable, so if they're in shock, if they've got a systolic less than 90, if they've got heart failure, chest pain, you want to cardiovert them immediately. So you don't want to try anything else. So you want to do immediate DC cardioversion. If they're stable, we're going to try and convert them with some drugs. So amiodarone is the one used in VT. You can also use lidocaine or procainamide, but usually amiodarone is the one that you're going to want to go for. Do not use vampiril. If I remember correctly, it goes into VF if you do that. I could be wrong. Don't use vampiril if you've got VT. Amiodarone generally is quite a safe bet, even if you're not sure. So there's an algorithm here. Hopefully that's not too small, which again kind of just like outlines that if someone's got a shocky, it doesn't really matter what rhythm it is. We're gonna shock them, and then go broad versus narrow, and then irregular versus regular, and it tells you what to do. So this was one of the things that I remember, and also remember the doses. All right, so just one more question to go. So I'm going to pull up this one. I'm going to talk about murmurs. All right, got some answers in the view of time. I'm just going to move on. So yeah, well done. This is mitral stenosis. Yeah, so we're going to go over it in a second, but these are some very traditional some very classic signs and symptoms of MS in this case. So there's a lot of different types of cardiac murmurs. The most common ones I would say that is worth really knowing well would be aortic stenosis, aortic regurg, mitral regurg, and mitral stenosis. They tend to be the most common ones. This lovely diagram is from PassMed, but I think originally from Wikipedia actually. It's a really good one if you want to visualize your thing. And then just as a reminder, this is where you would listen to the aortic areas on the second intercostal space on the right side. You've got your pulmonary on the left side, and then your tricuspid, and then your mitral on the left lower sternal border. Yeah. So your mitral area is best heard on the apex, which was the case in this case, and it can also be heard if you rotate them on the left side. So you can radiate until the axilla. So we'll just briefly talk about those four murmurs. So aortic stenosis is a murmur that often presents with things like syncope or near syncope. You can have dyspnea and chest pain as well. So this is an ejection systolic, and it often radiates to the carotids. Because it's a right-sided murmur, left-sided murmur, left side of the heart, it's going to be louder on expiration. So remember the mnemonic RILE, so right on inspiration, left on expiration. So what I would get people to do is like breathe out and then stop mid-breath, and then you'd hear it in that. People can also have a narrow pulse pressure or slow rising pulse. A soft S2, an S4 will be present, a frill or LVH. Most common cause would be degeneration. And then in terms of management, if they're asymptomatic, generally observe, unless they've got a gradient of over 40. And then if they're symptomatic, you do a valve replacement. Establish a surgical valve if they're young and fit, and TAVI, transcatheter valve, if they're high risk. Going on to aortic regurgitation. So that's more common with things like dyspnea and orthopnea, and palpitations and chest pain. Your murmur is going to be early diastolic, and the regurgitation murmurs generally are things like they're blowing in character, sort of high pitched. You're going to have a very loud S2 as well. With aortic regurgitation, remember when you examine, you do the collapsing pulse. That's what you get with aortic regurgitation. You also get a wide pulse pressure as opposed to aortic stenosis, and you get nail bed pulsation and also head bobbing. Those are some quite rare signs, to be fair. It's often caused, so it can be caused by valve disease, so things like rheumatic fever or calcification, again, really common, can be caused by connective tissue diseases, or aortic root abscess. So things like hypertension, syphilis, Marfan's, Ehlers-Danlos syndrome, the list goes on. Generally replace it if it's severe or if they're symptomatic or have systolic dysfunction. All right, just briefly, because we're running out of time. So we've got mitral murmurs as well. So we've got mitral stenosis, like in this question. So very typical or very classical symptoms would be hemoptysis, as well as dyspnea. Your murmur is going to be mid-late diastolic. You're going to have a very loudest one and an opening snap potentially. The murmur is kind of rumbling and very low pitch. You can also have malar flush, and then sometimes it causes AF. Main cause would be rheumatic fever. There's some more rare ones, but I wouldn't worry too much about them. And then management, again, so if they're symptomatic, you might want to think about replacing them, and also manage whatever symptoms they have with it, so things like AF. And then mitral regurgitation, so again, it will be heard in the mitral area. It's often asymptomatic, but can cause things like fatigue and shortness of breath. Regurgitation, what I mentioned, so that's going to be blowing again, and it's going to be pansystolic, might radiate to the axilla. Going to have a quiet S1 and split S2 sound, potentially. Again, can be caused by rheumatic fever, but often is something like Alex mentioned, can be post-MI, or in infective endocarditis as well. Management, so you want to manage more the cardiac output, so things like nitrates, diuretics and inotropes. If they have heart failure, we're going to go through the heart failure management algorithm again, so things like ACEs, beta blockers. And then again, if it's severe, we're going to surgically repair it. It's better than replacing. The mortality rates, I think, and the long-term prognostics better if you manage to repair it, actually. So that's the guidance. And that would be all. If anyone has any questions, please do let us know, write in the chat or anything, or you can unmute yourself as well if you want to speak up. Yes, definitely we'll upload the recording and the slides on Medal, and we're also gonna upload the recording on YouTube and a bit as well when we manage to do it. So you'll be able to access that as well. So definitely go over it. And then yeah, there's some QR codes. I think the left one on the bottom is for feedback, but you yeah, we can do. I can send it out. There you go. There you go. And then you should hopefully get an email as well. And then if you haven't filled the survey, that's the QR code on the top. And yeah, that's it. Please let us know if you've got any questions or anything.
Yeah, we can hang around for a minute or so if anyone wants to ask anything.
All right, thanks everyone for coming. Unless there's any more questions, I think I'm gonna stop presenting now. And hope you guys enjoyed it. And then please do join us again next week as well. We're gonna have another session. I think it's respiratory next week. So please do join us, and we're gonna have a section every Thursday for the next few weeks. All right.